30 to 60 minutes, and usually, depending on how complex it is. Now, whenever we get transarterial valve implants, they are significantly complex. This is where surgeons find that it's difficult for the patient to actually have surgery. So then they will be given to, of course, a cardiologist, and they come to us for pre-imaging. So we need to sit there and we need to quantify this valve. We need to determine the exact length. And at the end of this lecture, I'm actually going to show you where wrong measurements have caused a detrimental effect to the patient outcome. So 55% is within the 45-minute mark, and this sounds about right. There are times when I can actually take longer hours, sometimes up to 2 hours, depending if they're heavily calcified. Great. So let's just take a look now at the aortic valve. This is a nice, healthy aortic valve. And as you can see here, we can see, the left coronary cusp, the left coronary cusp, right coronary cusp, and non-coronary cusp. It really depends if the patient actually has congenital anomalies. Then we can actually invert the images and we can actually look at the actual valve quite nicely. However, this is a healthy patient. What's interesting about this is when we come to scan patients with transarterial valve implants, and we're only looking at the aortic valve, we also like to do functional imaging. We like to look at different phases within the cardiac cycle. This allows me to see whether the end systolic phase gives me a larger diameter or an diastolic phase, which gives me the larger diameter. There is actually big changes and big effects when you have a small diameter in the systolic phase versus a larger diameter in the diastolic phase, or vice versa. So it's important when we scan these, we'll look at retrospective coronary CTA to allow us to look at this quite nicely. But this is the cue right here. So when I have to manually do this, okay, I need to work out the exact curved NPR, the exact line of fit. I need to be able to actually see the sinotubular junction, where I need to see the space between here, the actual sinuses here. When the valve does open up, it's going to push these calcified valves to the side. And this is the space, if I click here at the green box here, this is where it's going to land. If we look at the left ventricular outflow tract and this yellow line here, this is the anchor point of the actual valve. So about 6 years ago, when we first started doing transarterial valve implants, imaging was done as non-gated. And this is where we were not quantifying these accurately. And so these valves were slipping. Either they slipped into the left ventricle, or they slipped into the ascending aorta and caused thoracic dissection. So as you go along, we need to find these hinge points. So imagine trying to line up a four-dimensional structure in 2D. This made it very difficult to look at the right coronary cusp, non-coronary cusp, and left coronary cusp to get them all in the one line. There was intensive research and studies, and especially in the American College of Radiology and of course the cardiovascular CT group in the United States. They tried to find a unified way of being able to get this annulus diameter and the hinge points in one line, because this is where the errors were happening when they were deploying these actual aortic valves. So then they came up with these double oblique lines. They told you to start from one end to the other end. There were multiple steps, and this was very user dependent. There was no consistency, and there was a lot of errors. This made my job a lot harder. We had to go back and double check these images and also these measurements before we released these to the cardiologists. And again, when we place the valve, we need to look at the distance between the left ventricular outflow tract and the right coronary artery and left coronary artery. If the distances between the left ventricular outflow tract and the coronary arteries on either side were too low, and we opened up this valve where we had the old valve being pushed aside, we're going to cause myocardial infarction and reduced blood flow or complete obstruction of blood flow to the coronary arteries. Significant, consistent imaging and measurements is vital. And what's more important, if someone goes away on a holiday and they're not experienced in this, we're not going to have consistency in results. which is going to affect patient outcomes. So as you can see, the amount of work that it takes to go into looking at these left ventricular outflow tract, the hinge points, the way that the valves are going to open up and squash onto the sinus of the coronary arteries, is there going to be effect? And what's even most importantly, are we going to have the right angle at which the cardiologist is going to deploy? So now I ask Yannicka to show me, to give me access now to the live TAVI software on the IntelliSpace portal, and I'm going to show you where something takes 50 minutes or an hour. We do this in 2 clicks. So if you have a look right now here, this is a standard gated CTA. The patient is obviously not very well. There's some movement artifact. But as we zoom up, okay, I can actually show you the hinge points. Automatically, the software will select this. If I zoom this right up, I can now look at that this is not circular. This is actually elliptical left ventricular outflow tract. As I come up, it will be so hard to look at all 3 planes. But with one click of a button, I have my hinge point right there. It's selected my right coronary arteries. It's also selected my left coronary artery. If I'm even not happy with this, I can go back and change it. And what's more important now is I have color coding system. This allows me to confidently sit with the cardiologist before he goes in. Before he actually sends away for the which valve he wants to use, we can measure this carefully and accurately. Now if I show you another way that we look at this, so I can choose to accept it or not. I can look at my aortic sinus, which I've got my hinge points. I can now look at the heights of my right and left coronary arteries. And guys, this is all one click of a button. If I'm not happy, I can change it. And if I want to, I can manipulate the actual information because I have all the data. I have full access to all the thin slice data and information. I don't have to wait for somebody to resend me the images. And this all can be done within 2 or 3 clicks. I'll be sitting at home at night in my bed, and actually you can do this and check this before the next day. I can click to accept it all, and then all of a sudden, I get full automated report. What's even more important now, it actually gives me the device. So if I double click on the 3D volume image here, and I zoom right up, it now tells me dedicated information. It shows me the hinge points. If you look below on the bottom right hand side of the screen, I can give me the cardiology or the interventional radiological angle at which the cardiologist needs to be at to see the 3 hinge points, to see how he's actually, in which plane he's going to deploy his stent. And this will reduce the amount of error and give greater confidence to both the cardiologist and radiologist when they're deploying the stent or the actual valve and when they're opening it up. What's more important now, also, I can accept the plan that I want, and once I accept it, automatically I need to go back and accept every single point. And now I have full access to this information. If I want to change the actual area diameter of the actual valve, of the actual left ventricular outflow tract, whether at the subtubular junction, LVOT, or at the sinus junction, I can do that just through a simple click as you see right now. This has allowed me to have full access to my data, making it the Ferrari of medicine. So then also, I don't have to sit there and write in the report. This here is the long axis, this is a short axis, and type them in. I can now just copy paste it and put it straight into my radiology report. Now, consistent results, and I can have saved these images on PACS. And also, because this is integrated into PACS, or the RIS or the HIS, or even the EMR, I can go back and click where I left off, or where the radiology resident left off, just to check. Now, if I look here as well, I can click on the optimal cath lab angle. This will now give me a tolerance to how much cath lab angle I need to be. If I have too much tolerance, if I'm at the wrong angle, then my hinge points are going to change. It gives me the ideal and the exact point of what to do. This is where previously there were significant errors and issues in transarterial valve implants. And so now we're going to actually go back to the presentation, and Yannicka will allow me to go back to the presentation. And look at this here. If I show my arrow, this is a coronal MPR of a transaortic valve implant And this was only done, guys, 2 months ago. So this is new. Even with the modern technology, they got the valving done wrong, because what happened was, this is not a patient that was done at our institution. This was done outside our institution. The imaging was done with us, and they decided to go and have it outside to another cardiologist. The left ventricle, they actually picked a smaller size because they decided to go back and do it manually themselves. As you can see here, it's being pushed back. There's, of course, left ventricular hypertrophy. It's pushed back and it's caused an aortic dissection in the ascending aorta type A. If we go to the next image, in actual fact, we have a double aortic dissection. So here we know that the angle is less than 90 degrees. This is the true lumen. We have two double false lumens. This now is going to be very detrimental, and he has enlarged ascending aorta. So ultimately, when we're looking at advanced processing, when we're looking at radiological information and imaging, when we're looking at where we fit in the holistic approach in the patient's life cycle, from birth to death, from treatment to detection, from diagnosis to outcome, it's all about time. It's all about access to information. So if you have a look at this screen here, I don't need to wait for a workstation anymore, because I like to look at CT, MR, PET, PET-CT, PET-MR, ultrasound. I have access to all the information as a one-stop shop. Patients don't have to wait longer because the neuroradiologist is away on holiday and the other guys are not confident in reporting it. Now, I could be even in Hawaii having a mojito and actually log in and actually have a look at this patient really quickly, just to make sure to give a second opinion. Or I can actually go to the United States, or I can go to Europe in Paris, or Italy, Belgium, anywhere I want, to any of my friends, and I can ask them, can I please have a second opinion? It is instantaneous, and they have full access. More importantly, consistency in results. If I have tumors, the tumors are on the rise. Imaging technology is detecting things a lot quicker and a lot better. I want consistency in results. I do not want to send my patients on a roller coaster ride based on it's enlarged or it's reduced. I want to be able to confidently tell this to the referring physician so he can confidently tell that patient. And if I create this strong relationship between radiology and the referring physician, they will show greater confidence in our ability as well as what we show in their ability, and the patient ultimately wins. Is there any questions anybody would like to ask in the box below? So it's very nice of you all to say thank you.
We will wait for some questions. I think there are going to be some long questions because multiple participants are typing. So let's wait for it.
So I'd probably just want to add one more thing while everybody's writing their questions. Just remember, we in radiology now have healthcare at our fingertips. We now have access to all data, to all information. If we're unsure about an imaging modality, we can use multi-modality imaging. If we want to make sure that the radiologist, radiology resident, or radiographer has done the correct way in post-processing, we can go in there and fix it before it's distributed on the PACS system. Even if we want, we can give access to our cardiologists so then we can make them a part of our team. This goes bigger and better. When I go to my meetings, I don't need to get my secretary to give me a list of all the patients. I now log in on IntelliSpace up in the surgical room, and actually I have access to all the information anytime I want. If they're unsure about a measurement, I have all of it there because everything on my fingertips. Great. So we have a question here. First of all, it's very nice of you all to say thank you, and I'm glad you've all enjoyed it. So here we have a question. What would you want to see coming up in the next few years in the domain of post-processing? I tell you what, the sky's the limit, and we need to be at the forefront of this information. The most important thing is we need to have access to all the raw data at our fingertips. We don't have access to this, we're still going to have a few bits of guessing games, and then the radiologists will have conflict with other physicians when they're going to say, no, the radiologist was wrong in his report. It wasn't a 75% stenosis, it was actually 60%. So what I would like to see in the future, of course, is happening right now. Access to all the data, being able to look at the data anytime, anywhere, wherever I am in the world, and of course, having collaborations, being able to work with my colleagues all over the world, whether in radiology or not, and getting a second opinion in case I don't get it right, or in case I need a second opinion. I hope that answers the question.
Okay, thank you very much. Oh, there's one other question coming in.
Okay, so there's another question. How do the results from TAVI packages used? The report is sent to the value vendor. Do the cardiologist want to see his planning during the TAVI procedure? Absolutely correct. And this is an excellent question, and it's an important question. The cardiologist not only just wants to look at the images within the aortic valve, he wants to look at the entire vascular tree. We need to look at tortuosity. We need to look at multiple calcifications, whether it's singular or concentric. We also need to look at the incision point. If the common femoral artery has a small, narrow, less than 6 millimeter diameter vessel, if he's going to puncture that artery in there, it's actually going to cause a lot of rupturing or bleeding, and we've seen that in multiple cases. The second thing is cardiologists today are actually finding it more interesting to be a part of the radiology team. And what's even more vital than this is whenever we do the imaging, we do the actual workup, workstation, and results, we're actually finding more and more integration where they're asking radiologists to go up to the lab, to the interventional lab, and they want us there with them while they're doing this procedure. And what's even more important is this. I can actually make an interventional bookmark. I can bookmark exactly what I want the cardiologist to see, and he can actually log in anywhere he wants, and you'll have that login for him. I can send him this link, and I can send it to him via email. This is the beauty. Once I have done it, I send it to him via email. He can go in and click. He opens it right up after he gets a security alert, because there's multiple security levels, so we need to be sure that we protect this data of the patient. And he can actually see exactly what we have done. This is the beauty of what this software can do. We're not talking about a software where you have on your phone, where it's an Android or an iPhone. We're talking about a holistic approach to information. This information, we can manipulate it. We can actually do what we want with it, and it is automated. These strong engines automate all of this information, making our workflow significantly faster by 90%.
Hey, thank you very much. We would like to thank, in particular, Dr. Saade for his excellent presentation and really the nice 3 clinical cases, which gives us and the participants a really good insight in the IntelliSpace portal. So thank you very much for that. We would like all the participants to let us know how much you enjoyed this webinar. So there's a little poll for that. Okay, I think people really enjoyed the webinar, so that's good. Then for the participants, in case you would like to ask additional questions, these are some of the contact persons within the different regions of Philips that you can connect to for any other questions. So thank you all for your attention, and we wish you a good day.